So, in applied behavior analysis therapy, there are two main things that we do in a clinic for every case. We use acquisition programs to teach new skills, and we treat their problem behavior. To be able to treat problem behavior, we need to be able to measure the behavior and understand the function. This is done with data collection, which is what makes us an evidence-based therapy. Behavior analytic procedures have been evidence-based since the beginning of the field in the mid-1960s. We believe all therapies should adopt some similar sort of accountability system so that consumers can be informed of the effectiveness of the treatment. There are tons of ways to measure behavior. Here are the most important. We may perform a count of the behavior, which is a simple tally of the number of occurrences, or the rate or the frequency, which again is the number of responses per unit of time. Duration, which is the amount of time in which the behavior occurs. Response latency, which is the measure of elapsed time between the instruction and the onset of a response. Or inter-response time, which is the amount of time between two consecutive responses. All behavior has a topography and a function. The topography is the physical form or shape of a behavior. It must be measurable. You can often answer the question of a topography of a behavior by asking, what does the behavior look like? Whenever a patient is engaging in inappropriate or problem behavior, we typically record this on ABC data sheets. It's a narrative procedure where we record the antecedent, so in a box we write everything that was happening prior to the occurrence of problem behavior. The antecedent is not always clear, but do know that behavior never comes out of nowhere. Then in a box we may describe what the behavior was. Remember that the behavior must be observable. One way to test if a behavior is truly a behavior is to perform the dead man test. It's said that if a dead man can do it, it may not be behavior. And while that test has some flaws, the main idea behind it is very admirable. We don't say that a patient got angry, because being angry itself is a feeling, is something that you may not be able to observe. What you would write about are the physical signs that let you know that the person may be angry. For example, the patient's face got red, the patient began to cry. Then we write in another box about the consequence, which is everything that happens in the environment immediately after a behavior occurs. The consequence will lead us to the function. The consequence is often what is maintaining the behavior. It's important to note that if a patient wasn't getting what they wanted out of a behavior, they wouldn't be engaging in that behavior. So even though it may not be obvious what they're getting out of the behavior, it is something. Everything you see people do has a cause, and there are 4 functions of behavior: escape, access, attention, and automatic reinforcement. Finding the function or cause of a behavior means that the behavior analyst can develop the most effective and humane treatment possible. The absolute best way to determine the function of a behavior is to perform a functional analysis. It's an experiment which allows you to put the patient in different situations to see if the behavior occurs. Here's a quick guide for determining the function of a behavior. Escape-maintained behaviors typically occur following the issuing of an instruction or being in demand. The patient has to have something to escape from. We may see escape-maintained behavior whenever we say, hey, it's time to do some work, or we're going to do this, and it's something that the patient typically doesn't want to do. Access-maintained behavior is typically seen when the patient is trying to gain access to a tangible or an edible reinforcer. Typically, this will look like a patient maybe grabbing at something or repeatedly or inappropriately asking for an item excessively. I could say last week I saw a patient ask for a cupcake, even though they already had one, probably 45 times in a period of about 20 minutes. Access-maintained behavior also may look like crying or screaming whenever items are removed, and this can occur inside of demand or outside of demand. Attention-maintained behavior typically occurs outside of demand. which when you think about it makes sense. When you're in demand, you're typically working with a patient. If you are working with a patient, they should already have your attention. So attention to maintained behavior, meaning that they want attention, would typically occur outside of demand. And we typically see this when our behavior technicians are distracted by other tasks, like maybe talking to their supervisors or their parents, or even writing on their data sheets. The fourth function of behavior is automatically reinforcing. Sometimes you'll hear this referred to as sensory, but in the field of behavior analysis, we typically stick with automatically reinforcing, which that it means it's reinforced by the self, not by someone else. It's not socially mediated. And automatically reinforced behaviors, because the reinforcement comes from the self, they occur at any time. They may be difficult to interrupt. Oftentimes we see those self-isolating and repetitive behaviors, or those rigid behaviors, as things that are potentially automatically reinforced. When you are in session and it's time to treat problem behavior, it's very important that you first watch your own behavior. You don't want to accidentally reinforce the patient's behavior, so as quickly as possible, you need to identify the function. If there is a treatment protocol in place for a particular function, go ahead and implement that treatment now. If the patient has a particular procedure for attention-maintained behavior, this is when you'll want to implement it. You also have to pay attention to the environment, because if the patient is alone in a session room, or if they're in a classroom, may change the way that you're going to treat that problem behavior. For example, if a patient is engaging in attention-maintained behavior and it's just you and the patient in a session room, it'll be very easy for them to be in a situation to be ignored, because you'll be the one doing the ignoring. But if your patient is in a classroom and they're engaging in attention-maintained behavior, it may be more difficult to ensure that they're not receiving attention, because it may be very hard to tell 15 other students not to pay attention to the student who's engaging in the problem behavior. Stick to your guns, but reevaluate if what you're doing is not working. So if you believe that problem behavior is escalating, maybe you are treating it the wrong way. Maybe it's attention maintained and you're treating it as escape maintained by making them do work, but the behavior is getting worse because they're actually getting your attention. Or maybe you thought a behavior was attention maintained, so you're ignoring them, but now you find that your patient is nowhere near coming back to the table or coming back to work. It's possible that maybe it was an escape maintained behavior that you just reinforced by ignoring them. Then you should identify calmer behavior or the occurrence of the behavior that you're looking for. You may have to reinforce the behavior at this step. Then you want to record your data, and then you need to progress after your problem behavior. In the moment of problem behavior, again, stay calm. Watch your own behavior. Pay attention to what you do and say, your facial expressions, and your body language. Also, don't talk about the behavior in front of the patient, regardless of functioning level. Oftentimes they can't hear you and it may even change their behavior. Safety is always a priority for us. If you find that problem behavior occurs and you need to modify your dress, do so quickly or discreetly. We typically advise our technicians not to wear earrings or things that can cause injury if they're pulled on. But if the situation does occur where you are in earrings or a necklace, just remove them as quickly and as discreetly as possible. In situations where escape is the function of the behavior, which is any situation where an instruction is issued and the patient is non-compliant or engages in disruptive behavior, the technician working with the patient will follow through with whatever task or instruction was issued before the occurrence of PB. Prompt the patient as necessary for completing the task. If the patient remains non-compliant, continue issuing similar instructions and prompting responses until an appropriate behavior is discontinued. Then, represent the original task. Remember, you don't want them to escape that task, so they have to do it by the end of their problem behavior. If the patient is compliant with the original task, you can discontinue. If the patient is not compliant with the original task, prompt them again and begin issuing similar instructions until they are compliant. Now, if you have a patient that can't be prompted due to physical limitations, but they're still non-compliant, issue other instructions that the patient is likely to be successful with. If the patient is successful with instructions, begin issuing instructions similar to the original instructions to maintain compliance, then represent the original task. If the patient is compliant with the original task, you can discontinue. If the patient is not compliant with the original task, issue high probability instructions, and repeat. Individuals working with a patient shall engage in the least amount of eye contact and vocalizations as possible. Your tone should be neutral, not happy and reinforcing and exciting, but also not scolding. Very neutral. Individuals working with the patient shall not engage in scolding, reasoning, or bargaining with the patient at any time whatsoever. And brief verbal praise shall be given for any compliance displayed. When you're treating escape-maintained behavior, allow only necessary minimal changes for safety to the environment during problem behavior. Making environmental changes could delay a task, which could reinforce these escape-maintained behaviors. You may have to engage in pace prompting, which is where you utilize a neutral tone and issue several instructions back to back to back, and if a patient is not engaging in those instructions within 2 to 3 seconds, you will prompt them. So even though you can't see me right now, an example of what pace prompting may sound like would be touch your head, clap your hands. And if in those moments the patient isn't responding, they'd be prompted. So touch your head, prompt, clap your hands, prompt, touch your knee, prompt, wave your hand, prompt. It's very, 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 very important that you follow through with all instructions that you issue to a patient. It is very important that they learn compliance quickly. As a behavioral therapist, what you're doing is for the good of your patient, and it is something that they need to be taught to listen to. So if I say, hey, clean up those toys, and my patient says no, within 2 to 3 seconds, my butt as a therapist better be across that room getting ready to prompt that patient to physically pick up those toys. If I have to gently grab their hand and make them pick up the toys, that's what you're going to do. And you will do this every single time an instruction is issued until a patient learns to comply with the instructions that you give. And I promise, if you are following through with every instruction, it doesn't take a long time for your patient to pick up on that contingency. Sometimes our patients will use challenging behavior to express a need or a want. Typically, the patient is attempting to gain access to a reinforcer. If it's appropriate or allowed for the patient's request to be granted, but they are asking inappropriately or grabbing at the items, pointing to the items, screaming, the individuals working with a patient shall not allow access to those items until the appropriate demand or asking occurs. If the patient does gain access to the items will be immediately removed until the appropriate demand occurs. All inappropriate behavior shall be ignored as long as access to the preferred item is prevented and the patient is safe. We can't prompt demands or appropriate asking during extreme problem behavior. But once the patient is no longer engaging in extreme problem behavior, prompt the patient to appropriately ask for the preferred item in the absence of this inappropriate behavior. Try to get them to communicate as appropriately as possible based on their skill level. Replace the inappropriate behavior and reinforce the appropriate response. Be responsive to appropriate demands. If it's inappropriate or not allow for the patient to have access to the item, the individuals working with the patient shall not allow access to those items. Rephrase options if necessary. If the patient does gain access to the items, remove the items immediately, giving as little attention as possible. All inappropriate behavior shall be ignored as long as access to the preferred items is prevented. In situations where attention is the function, ignore all inappropriate behavior that is maintained by attention. After cessation of inappropriate behavior, allow the patient to comply with the task. If the patient successfully complies with this task, provide the patient with attention. Please note that with attention-maintained behavior or any other inappropriate behavior, always keep the patient safe, even if we must break our typical procedures. For example, if I have a patient that loves physical touch and climbs on top of their desk for attention, but they're at risk for flipping the desk over, I will physically remove that patient from that desk, even though the physical touch may reinforce the behavior, because it's more important that they do not flip the desk. It's important to know what ignoring actually is when we're talking about attention-maintained behavior. When you're ignoring a behavior, what you're doing is simply not acknowledging that this behavior is taking place and continuing on as if it is not happening. Ignoring a behavior is not physically turning away from the patient or praising other kids for not engaging in the behavior. For example, if a patient is talking and you say, "Wow, I love how other patient is being so quiet right now," you're not ignoring the talking patient. If they're high functioning, they're clearly realizing that you're talking about them. Ignoring is not stopping work until the patient is no longer engaging in the inappropriate behavior. And ignoring is not making comments about the kid's behavior. If I am talking to another person and a patient is hitting me for attention, I'm not going to react, I'm not going to flinch, I will not look at them. I will continue talking to the other person until the patient is no longer hitting me. In situations where automatic reinforcement is the function of behavior, remember to prevent or block the patient from engaging in any inappropriate behavior that may be automatically reinforcing, if we're intervening on the behavior. And if the patient cannot be prevented from engaging in the activity, remove any related environmental stimuli and engage in actions that prevent the patient from engaging in that inappropriate behavior. As with the other behaviors, the patient should be provided with as little eye contact and vocalizations as possible during this time. The individuals working with the patient shall engage in any actions needed to maintain a safe, healthy, sanitary working environment. Brief verbal praise shall be given for any compliance displayed. The patient must display compliance to a minimum of one task before receiving reinforcement. Remember that verbal praise shouldn't call attention to the problem behavior. One way to prevent or block automatically reinforced behavior is to issue incompatible instructions for redirection. For example, if a patient is hitting themselves on the head, simply instruct the patient to clap their hands. Remember, if they do not comply, you will physically prompt them to clap their hands, but they will not be allowed to hit themselves on the head because their hands will not be available. Again, remember to control your own behavior during problem behavior. Do not take this personally. Treating problem behavior is a part of being a professional. It's also important to remember not to blame the child, but to blame the behavior. This behavior is something that they have learned in their past. They would not be engaging in this behavior if they had an easier or more preferred way to communicate. To make anything a habit, do it. To not make anything a habit, don't do it. To unmake a habit, do something else in replace of it. Use descriptive praise and instruction to replace inappropriate behaviors with more appropriate behaviors. The appropriate behavior should always be determined by the patient's age and skill level. It may be more appropriate for a 2-year-old to say potty please, but more appropriate for a 5-year-old to say can I go potty, or a 10-year-old to ask to go to the restroom. Look for natural teaching opportunities throughout a session. If you are working on manding and a patient says potty please, but you're trying to increase the complexity of their questions, this can be an opportunity to allow them to ask in a more appropriate way. Please be responsive to appropriate demands and conversation. If you are actively trying to teach a patient to ask for something correctly or trying to teach a patient to engage in conversation, and they display any of those skills outside of the desired trials, always reinforce them. You're not only trying to teach a patient to speak appropriately when you're demanding it of them, you want to teach it all around. So if there's any occasion where they display a skill independently, of course you want to make a big deal about it. Because we want to teach alternative behaviors, it could benefit us to identify precursor behaviors to the problem behavior so we can replace those behaviors before they even occur.